Okay, so now that we're finished talking about the way the menstrual cycle works, and then of course the various forms of contraception, we're moving on to the various abnormalities that can occur in the menstrual cycle. Now, as usual, anytime we talk about any kind of abnormalities on STEP, it's a common theme to see that oftentimes in questions, things will be presented that are actually normal, but they're going to try to make you think it's an abnormality. So, just be very cautious when you're trying to figure out whether or not something is completely normal or not. If you are a woman, then maybe you'll have a better understanding of something that may just be normal, maybe because you've gone through it. But abnormalities to the menstrual cycle are definitely a topic that uh, both genders need to learn very well, and men need to make sure that they spend even more time on really grasping it all. The part where it gets really difficult to differentiate what's normal and what's not is the menstrual things that can occur right in the beginning to a really young girl who just started menstruating. At that point, there are all kinds of things that can occur that are very much normal, like having uh, menstrual cycles that are very abnormal, or a menstrual cycle where maybe you have menses every 2 months, something like that. Anovulatory cycles and stuff like that. These are all very common, quote unquote, normal things that can occur to young girls who just recently started menstruating, just because their HPO or HPG, hypothalamic pituitary gonadal axis, or HPO, hypothalamic pituitary ovarian axis, just started really maturing. So the hormonal balance there isn't exactly optimal yet. Here, the first topic is primary amenorrhea, or delayed puberty, the absence of menses by age 15 with secondary sexual development present, or the absence of secondary sexual characteristics by 13 years of age. Right, so it's really just the absence of one or the other. Right, so you can see there's two things here. The first one was not having menses, but even though this girl may not be having menses by age 15, she should have secondary sexual development. Right, so Tanner stages should be matching up, which we looked at last time. Yeah, right here. Right, so by age 15, you can see Tanner stage 5 already, which it's pretty easy to memorize since stage 5 and 15. Right, so it's very easy to memorize. You should know that stage 5 is age 15. So if you have a girl who's age 15, but then her presentation is very much like stage 2, then that's definitely pathological. Something's wrong. All right, so that's one half. And so just the absence of menses with secondary sexual development is fine, or the absence of secondary sexual characteristics by age 13. Right, so if Tanner stages are just taking really long to come, that's the delayed puberty part. So history, presentation, and physical exam, absence of secondary sexual characteristics, no estrogen production. So anytime you have a patient with absence of secondary sexual characteristics, the first thing you want to think of is they must not be making enough estrogen, right? So remember that right now we're just talking about females, right? This is the gynecology section, just women. So for men, secondary sexual characteristic development and pretty much all sexual development and everything is just all testosterone. Women have estrogen and progesterone, but progesterone is just progestation. It's really just for pregnancy related topics, not anything else. So estrogen is the main hormone that gives female type physical development. Um, and you can actually induce female type development even in men by giving men a lot of estrogen. Right? So that's something that can be done as well. So there's multiple reasons you could have a woman with absence of secondary sexual characteristics. Anything that would cause no estrogen production, such as primary ovarian insufficiency. Right? This is the most common cause. Depletion of ovarian follicles and oocytes, most commonly from Turner syndrome. Also consider history of radiation therapy and chemotherapy. So Turner syndrome, as uncommon as it may be in the real world, it makes for great questions, right? There's so much you can ask. I mean, Turner syndrome has big time cardiovascular questions, big time reproductive questions. You can even just ask general genetic questions. So in such a question where they're trying to present a girl who has absence of secondary sexual characteristics, the first thing after thinking no estrogen production, you should think, why would there be no estrogen production, and Turner syndrome should come to your mind. Like, this is the thinking that should be going on in your mind as you're reading this question, where this girl apparently has no secondary sexual development. Also consider history of radiation therapy and chemotherapy or gonadal dysgenesis, which these are not things you'll have to consider. These are things that are going to be in the question, right? Like in the real world, yeah, sure, you need to consider these things and ask. Now, the hardest types of step questions are usually where they're going to be like, oh, what should be something you should consider? And it's never worded like that. It'll be like, what test should you order next? Or what should you ask the patient next? Stuff like that. So this is where you're supposed to consider. But generally speaking, the question will tell you like, oh yeah, this patient had some kind of maybe endometrial cancer, got radiation, or something along those lines. And then that's going to be something you'll of course highlight, and then it'll help you key in on something that could have possibly occurred. That may be a pathological focal point right there. Central hypogonadism. There's another case scenario. So this is where anything that stopped you from making the hormones, right? So central, though, so in the brain. So what tells you to make estrogen is not being there anymore. So there's multiple reasons. Now these are all different questions. Each one of these is a question of its own. Undernourishment, stress, hyperprolactinemia, or exercise. This is usually seen oftentimes in some level together, where it might be a girl that is very athletic. She might be, dieting heavily, exercising way too hard because she's preparing for some kind of, marathon or athletic program, and she's basically going to be too undernourished to have menses, right? There's just no blood to waste. A CNS tumor, such as a platinoma, right, or cranial irradiation, any irradiation in the brain that may have caused the central hypogonadism is something you have to keep in mind. So as usual, radiation therapy is always a key thing. This has been a topic from the beginning, though. Remember, the beginning was cardiovascular. That was our first topic. And anytime we saw questions about people who may have gotten chest radiation, we cared about them having some kind of pericarditis, possibly, right? So that was something that has always been a thing. Common syndrome, usually one of the easiest questions, where it's going to be the guy that can't smell anything, the girl that can't smell anything, right? So common syndrome, it can occur to guys too, but here we're talking about females. So the key feature they have is not being able to smell anything, right? Isolated gonadotropin deficiency. And so these are all different things that can cause you to not really have GnRH, gonadotropin releasing hormone. Now, if you do have presence of secondary sexual characteristics, then that's that first scenario, right? Absence of menses, but you do have secondary sexual characteristics. So here, estrogen production, but other anatomic or genetic problems, right? Etiologies include the following. So there's Mullerian agenesis, imperfect hymen, incomplete androgen sensitivity, and let me see if there's anything else actually. And congenital adrenal hyperplasia, all of those. In between, they have all these charts for what we looked at already, which was the contraception. So first one, Mullerian agenesis. This is the absence of the upper 2/3 of the vagina, right? Uterine abnormality. So we're going to go back to step 1 and look at all these topics. These were topics that were all in step 1. So whenever you have Mullerian agenesis, remember that there was the Mullerian and then the Wolffian. The Wolffian duct was mainly for men. The Mullerian stuff was all for women. And when this isn't there, you're going to have presence of secondary sexual characteristics because everything else is working fine. But since there are no upper 2/3 of the vagina, that's going to be something where it's going to be difficult to really tell what's happening, and questions are going to try to make it even harder. We're going to see a bunch of practice questions to understand these things. Imperfect hymen. So this is just a hymen that never really opened up at all. So there's no opening. So this is going to be another case scenario. We're going to have absence of menses, right? These are all case scenarios where you may have absence of menses. So here you're going to get something called hematocolpos, where because menses is occurring right behind the hymen, there's going to be a lot of blood pooling up. So there's going to be blood in the vagina, right? That cannot escape, along with the bulging hymen. And that's the key giveaway. Like, imperfect hymen is an extremely easy question. The key giveaway for an imperfect hymen is always going to be that they're telling you there's a bulge on the hymen from inside. So then, of course, that means there must be something pulling up on the other side of the hymen. And that's only just a menses question. complete androgen insensitivity. Just reading from the name, you should know exactly what that means. That androgens are being made. Patients present with breast development because of aromatization of testosterone to estrogen, but are amenorrheic, and the number one key feature is lacking pubic hair. So if you ever need to differentiate between multiple, disorders of sexual development, DSDs, that's what they were called in step one. If you need to differentiate between multiple disorders of sexual development, this is one of the differentiation factors for complete androgen insensitivity. They do not have any pubic hair because they have complete androgen insensitivity. Without androgens actually reaching your pubic area, skin and hair follicles effectively, there's going to be no pubic hair. All right, so that's something that helps. Now, they wouldn't really have breast development either, but aromatase can convert testosterone to estrogen, and that helps them with the breast development part. Right, so they're still going to have, as we said, presence of secondary sexual characteristics. They may be lagging behind a little bit though. That does happen because there isn't enough aromatase activity to really make up for all the estrogen, right? So they might be like maybe 15 or 16, but they might be Tanner stage 4, right? And you know from the simple memorization tool that Tanner stage 5 is 15 because both numbers have a 5 in it. So if you're above 15 but below Tanner stage 5, then that is somewhat concerning. Not heavily concerning, because remember, everyone develops differently, everyone has their own pace of growth, but some things are far more concerning than the other. And this is definitely, a 16-year-old girl who's Tanner stage 4. There's something to be of concern there, and you have to dig more at that point, but never dig too hard. There's going to be a bunch of questions that are going to try to present to you a girl. They'll be like, here's a girl, this is how she's doing, this is her development, Tanner stage, blah blah, all this stuff. They'll tell you all these details about her, and then you'll have to figure out if all of that is acceptable and physiologically normal, or do you need to order some kind of test. And then tests you can order may include things like doing a genetic exam, checking for any one of these things, right? Malarianegenesis, CNS tumor, hyperprolactinemia, etc. Or is it all just simple constitutional growth delay that's going to be made up for and no tests are necessary? So something like that is going to be a very common scenario, that when you do those practice questions, whether you get it right or wrong, you're still going to learn something. You're going to learn something, and if you get it wrong, you'll definitely be learning a lot of things there. So there's that's definitely a conceptual thing that is very important to grasp. We're going to see more of that as we do all our practice questions. Congenital adrenal hyperplasia, which we definitely mastered very well in step 1, and we'll revise it here again just to make sure that mastery really sticks. This can also present as realization with amenorrhea or oligomenorrhea. Often presents in infancy with ambiguous genitalia, and that's the key thing. Right, so each one of the adrenal hyperplasias had their own thing, right? 17, 21, 11, and what hormones were high always dictated the symptoms you would see, and what hormones were missing dictated some of the other major issues you would note. But one of the key things that they all were missing was that they were all low in cortisol. So we're going to go back and see that as well as we approach that topic. And then PE, pubertal development, genital exam, signs of androgen excess, physical features of Turner syndrome. These are all things you would look for. Right? For Turner syndrome, think streaked gonads, shield chest, amenorrhea. They always have this really weird collection of skin behind their neck, so that's called the webbed neck. Aortic coarctation, which of course leads to hypertension presentations, and a bicuspid aortic valve, which can also lead to aortic regurgitation and all kinds of other issues. The first step in the workup of primary or secondary amenorrhea is, of course, as usual, a pregnancy test. And we're going to see that. Right? How do you diagnose this? Perform a pregnancy test. That's the first thing you want to do, because anyone, literally anyone that comes in saying, oh, I haven't had my period yet, and they've already started menstruating in their life, the first thing you should consider is they might be pregnant. Right? And in the real world, oftentimes at this age, 13, 14, 15, girls are extremely reluctant and too scared to actually tell you, yes, I had unsafe sex, I may be pregnant. Right? So that's something that you order the pregnancy test regardless of what's happening in the question. Right? assess for anatomic abnormalities now, right? Check if there's something physically wrong. Physical exam, ultrasonography, right? If the uterus is absent, then it's not a girl. Now, this is a really difficult topic. So in STEP, oftentimes what will happen is they'll tell you, hey, you have this girl as a patient. You know, they literally might start a question like this: a 15-year-old girl is brought for blah blah blah, and then it turns out it's not a girl, it's a guy, right? So the absence of a uterus is like number one for understanding that it's not a girl, because to have a uterus you have to be a girl. Those are the hormonal changes and the chromosomal necessities to actually make the uterus. And when you see this, when you see that there's an absent uterus, you know, in a girl who's coming in because she hasn't had a single period yet, even though she might be age 15, which is Tanner stage 5, then you do a karyotype and serum testosterone check to assess if it's abnormal, right? Abnormal Mullerian development, where it's going to be someone who's 46XX, normal female testosterone levels, or androgen sensitivity with 46XY, normal male testosterone levels. Generally speaking, though, the karyotyping is going to be very critical here. Absence of the uterus really can occur only two ways, and that's what they're labeling here, right? The Mullerian development or the androgen sensitivity. But generally speaking, in all questions we're going to be looking at, when the uterus is not there, it's 99% chance it's a guy, right? And then you have to start reevaluating the question, understanding that this was just a guy who didn't develop correctly. What happened? What went wrong? Right? And that's going to be your androgen insensitivity, the 46XY, who just didn't develop in a very male-like pattern at all, and his genitals didn't develop in a male-like pattern at all because androgens were having absolutely no effect. We don't need only testosterone as men. We need dihydrotestosterone, like the stronger, much more potent version of testosterone, the DHT. But if you don't have any sensitivity at all to those things, then you don't develop, right? And then from your childhood, you'll be considered and assumed to be a girl, and that's how you're raised. And then this is actually a thing that occurs very commonly, especially in families that don't do regular doctor visits. You know, that's also very common. So you'll probably see that in questions, you know, that the patient comes from a family who doesn't really do routine doctor visits. Maybe they don't even believe in vaccinations and stuff like that. So it's gonna be there. Now, if the uterus is present, then first things first, you can rest assured it is a girl. So you can knock out a couple of choices there. And now you should check for FSH and LH levels, right? Because those are the guys that actually work towards causing menstruation. Those the central guys, right? Follicle stimulating hormone, luteinizing hormone are both having major interplay with each other to actually cause menstruation. Remember, there's the LH surge that causes ovulation. Then you have the high progesterone that's coming out to actually sustain some level of an endometrium. And then when all that dies out with the corpus luteum, boom, you get your period. So something may be wrong with those central hormones. If there's high FSH, then this usually means that you're really trying hard to stimulate your follicles, which means that your follicles must not be responding, so you try to make more FSH. If your follicles are not responding, it could be primary ovarian insufficiency, where you don't even have follicles anymore, and then you need to check to see if maybe they have Turner syndrome. So over here, once again, the answer is also karyotype. Okay, and then if the FSH is normal, right, or low, then that could be central hypogonadism, because there should never be a reason for low FSH. If it's low, it means you're not making it. There's no negative feedback kind of thing that stops you from making FSH. That's not really a thing. So it must be that you're just not making it, right? And then things that can cause you to really just not be able to make FSH would be like having too much prolactin. We know prolactin is prolactation, which means that you're not going to be getting pregnant while you're lactating. So, you know, that's something that always sticks to you. And thyrotropin, especially if there's galactorrhea, right? Because almost everything can have thyroid problems. A lot of girls actually don't start menstruating or have very irregular, abnormal menstruation cycles simply because they are hypo or hyperthyroid. You know, so that can be something that is concerning. If signs of hyperandrogenism are seen, right, then you have to consider a tumor that might be making too much androgen, right? Consider androgen secreting neoplasm, check for testosterone and DHEAS. dehydroepiandrosterone sulfate. If the patient is hypertensive, then remember hypertension was one of the things related to congenital adrenal hyperplasias, because that's glomerulosa fasciculata reticularis. The glomerulosa part was related to blood pressure with angiotensin and stuff. So that part can cause hypertension in people, right? That's mainly possible with 17 and 21. So we're going to see about that later on as we get there. So now, how do you treat this? How do you treat somebody coming in with primary amenorrhea or growth development delay? Well, if it's constitutional, as I said earlier, if it's just constitutional growth delay, nothing is necessary. And this is usually one of the hardest ones to pick. But at the same time, it's also not. You're going to learn as you practice more and more questions that when it's just constitutional growth delay, you'll see in the question everything is perfectly fine and the girl's doing her thing. You know, she's developing just fine. It's a little lagged, but she'll get there. You know, and it's very common to have constitutional growth delay. There's no real problem. Puberty just hasn't started yet, and eventually it will, right? They don't have a complete absence of anything. So you don't need to do any treatment, and you also don't even need to really order anything. But generally speaking, for all case scenarios, the very first thing that should have been ordered, and most questions will already do it, is the pregnancy test. So most questions will already tell you that there was a negative pregnancy test. So that part's done, and then you can move on to the next thing. If the problem is about hypogonadism, then you need to begin hormone replacement therapy, right? Once you figured out that the problem was she's not making enough estrogen or progesterone or whatever, start the hormone replacement therapy with estrogen alone at the lowest dose. Remember that giving estrogen can be really problematic, right? Estrogen can cause many cancers as well, causing hyperplasia of the endometrium, causing response to possibly, you know, somebody with a history of estrogen receptor positive breast cancer. You don't want to give them estrogen. So something like that. Begin cyclic estrogen and progesterone therapy 12 to 18 months later if the uterus is present, because again, if the uterus is there, we've always said this, if the uterus is there, you need to give both estrogen and progesterone. Otherwise, estrogen alone is just going to cause endometrial thickening, which is endlessly going to thicken, and then there's going to be endometrial cancer risk. If the issue is anatomic, like the imperfect hymen or any other issue, then if it can be surgically fixed, begin surgical intervention, right? So that's another thing. And then let me see how they finish. Oh, that's it. So that's the end of that primary amenorrhea topic. Let's also look at secondary amenorrhea, and then we're gonna go look at all the different things that we just scrolled over. A bunch of practice questions, a bunch of lessons. Secondary amenorrhea is secondary, so it's the absence of menses for 6 consecutive months who have passed menarche, but is due to something else. Like you have amenorrhea that's not really primary amenorrhea. It's not that you're missing some hormone that's critical or anything like that. It's actually amenorrhea because of some other central critical issue. For example, pregnancy. Pregnancy is a very physiological point where you have secondary amenorrhea, right? So a pregnancy test would be positive, and you'd be like, oh, there's nothing wrong with you. You're not menstruating because you're pregnant, and then we're done. Obesity, definitely a case scenario where you can get secondary amenorrhea. It's usually going to be related to the next topic, which is PCOS. As a primary ovarian syndrome is a very high yield topic. Another one we'll probably revisit the step 1 book to look at, where most patients present with both diabetes and obesities, and they need to be treated with oral contraceptives, right, to stop their follicles from developing. Any follicles they possibly have left should be stopped from developing. They should not be developing anymore, because they're all just going to continue developing into a cyst, and then that's going to be bad. It could also be premature ovarian insufficiency or chemotherapy. So we did question on premature ovarian insufficiency, where basically they ran out of eggs really early, and again, that super rare case scenario, but it can happen. So no more follicles for whatever reason. If the problem is in the hypothalamus, then as usual, it could be a neoplasm, it could be a functional hypothalamic amenorrhea due to the nutrition, exercise, and stress stuff we looked at. Systemic illness, right? Pituitary gland stuff was the prolactinoma, thyroid gland stuff was hypothyroidism, and uterus with Asherman syndrome and cervical stenosis. So we'll see questions on that. This one here is Asherman syndrome. a lot of overlap, as you can already see. Secondary amenorrhea, primary amenorrhea, there's a lot of overlap. Primary amenorrhea had more direct things that were kind of related to, like, just not having estrogen, period. When you don't have estrogens, you will not have your periods either. So that's like a primary thing. Another primary amenorrhea thing was when you're just not making FSH and LH. That's primary. But secondary is more so things that caused you to not make FSH and LH, or things that caused you to not make estrogen. That would be the secondary level. So there is overlap. They're pretty much very much hand in hand. And rarely will you get a question where you need to pick, oh, is this primary or secondary amenorrhea? If you have to pick between whether or not something is primary or secondary amenorrhea, they're going to have to pick answer choices that are completely not overlapping at all. Right? So that's going to be something. Otherwise, it's really just going to ask you for a root cause of the amenorrhea, and you're going to have to pick between one of these various specific answer choices, not vaguely over a bunch of things. So as usual, of course, you just do the pregnancy test. Right? If the pregnancy test is negative, then you need to check if her follicle is developing or not. So do the endocrine test. Because there's only two reasons. Very initially, there's only one reason you might not be menstruating, and that's because you are pregnant. Then if you're not pregnant, there's only one real reason you're not menstruating. Your hormones are not balanced. So you check all the hormones. Now, if you are not pregnant and your hormones are all perfect, then it's usually an anatomic problem where your hormones are trying to do their job, but you just don't have a functional body part somewhere that's not working. So the endometrium or the uterus, something is not working, right? So the thinking path here is very straightforward, right? So if negative for pregnancy, measure the hormones. Depending on which hormone is high, it should be a pretty obvious problem, right? If FSH is high, then as we said, you must not have enough follicles. So your body is really trying to activate follicles, but it's not working because you don't have follicles, right? Remember that when you make FSH, it goes and stimulates the follicle. And then if there's no response, no follicle is being stimulated, you'll release even more FSH in hopes of stimulating some follicle, but it won't work. That's your primary ovarian insufficiency. Primary because your ovary is the one that doesn't have anything. Secondary ovarian insufficiency is when you don't make FSH to go turn on the ovary, right? But primary means that the issue is inside the ovary, and that would be not having any follicles. If you have high TSH, then obviously that means that you're not making thyroid hormones, so your hypothalamus is releasing more TSH in hopes of making thyroid hormone. And without thyroid hormone, all development gets messed up, right? It's a very head to toe kind of hormone. Everything gets messed up. So you're going to see multiple symptoms in that patient, not just symptoms of estrogen lack. If there's hyperlactin, then that obviously means there's going to be a very high chance that the patient has a prolactinoma, pituitary adenoma. So you need to order an MRI. Right? Initiate a progestin challenge. So that looks like this. Progestin challenge is basically the progesterone withdrawal test. So in a patient who naturally has high estrogen but is not really menstruating well, you give progesterone, and then when you stop giving progesterone, you can see that they're going to stop the progestation part and menses will occur. So you're going to get withdrawal bleeding, right? Whereas here, when they don't have any estrogen at all, giving progesterone doesn't do anything. Progesterone comes in after estrogen has caused development of the endometrium, right? So you can see the difference here very clearly. So when you give somebody progesterone and stop, and then there was no withdrawal bleeding, that means that their problem is not that they just need progesterone. Their problem is they don't even have estrogen, right? So they need both things, right? So a progesterone withdrawal test is used in premenopausal women with secondary amenorrhea to determine estrogen status. No withdrawal bleed with low estrogen levels. It is not used in the evaluation of PMB because it cannot distinguish between benign and malignant causes. All right. So we're gonna see more about that when we go into more other questions. Premenopausal bleeding. So the progestin challenge withdrawal bleed indicates anovulation that is probably caused by non-cyclic gonadotropin secretion, pointing to PCOS or idiopathic anovulation. Right, so when you do this, when you do the progestin challenge test and there is bleeding, then that in America, that generally just means the patient must have PCOS. And then you just have to get them started on birth control, because you don't want them to secrete more follicles. And they can get pregnant, so that's always a question too. There's always that one bullshit question about whether or not some of these patients can get pregnant. So you have to remember that a Turner syndrome patient can get pregnant, just not naturally, right? So you can do in vitro fertilization to actually make a Turner syndrome patient pregnant, but they won't naturally get pregnant by themselves, right? So that's something that you have to understand. When they're asking you a question, you have to really focus on, do they mean naturally, or do they mean, is it even possible for her to be pregnant? Because if it's just about her being pregnant, then yeah, definitely she can be pregnant. It would just have to be instilled, right? It would just have to be done for her. Now, if there's a negative progestin test, and this indicates uterine abnormality or estrogen deficiency, mainly it'll be estrogen deficiency, that estrogen never even built anything for the progesterone to break. Now, progesterone doesn't break it. Progesterone is supposed to hold it. This is why when you stop giving the progesterone, it's no longer held, and then there's a withdrawal bleed, right? So here, there's nothing for the progesterone to even hold. So when you stop the progesterone, nothing is lost. If all of this is not something that's relevant, then you should check for signs of hyperglycemia or hypotension, right? Because these things, right, where there's polydipsia, polyuria, or blood pressure derangements, you now need to consider some level of maybe Cushing syndrome or congenital adrenal hyperplasia or Addison disease, which are going to be things related to the other endocrine. Remember, in step 1 there were 2 endocrines. There was the endocrine that talked about all the hormones that there are, and then there was reproductive endocrine, which was mainly just FSH, LH, estrogen, progesterone, all those guys. So you need to check for now the other, the complete endocrine checkup. You already did your reproductive endocrine check. Now you need to do the rest of the endocrine check, because it could be that they might have some kind of Cushing or really bad diabetes. Is it clinical virilization? So now clinical virilization is going to be someone who never menstruated, right? Because they were virilized to begin with. So you need to measure testosterone, DHEAS, and 17-hydroxyprogesterone to see what's happening. Mild and moderate patterns are not really tested that much. When they are tested, it's usually because it's just a normal thing. So, depending on what's happening in the question, there might be different things for you to look for. And treatment really just depends on what you found out to be the problem, right? So that's really all you can do. So for hypothalamic problems, reverse the underlying cause and induce ovulation with gonadotropins if they are trying to conceive. If they're not trying to conceive, get them on oral contraceptives, right? If you're naturally not having menses, then you definitely want to be on birth control so that you don't really mess something up, because it's kind of counterintuitive. So oftentimes people don't pick an as choice. Usually a lot of people consider birth control something that you do so you can stop menstruating, but that's not really what it is. You take birth control so you don't give birth, not so you don't menstruate. So if you're not menstruating, oftentimes girls will think, oh, if I'm not menstruating, I don't need birth control, because why would I need birth control? There's no way I'll get pregnant. No, you can possibly get pregnant. If by any chance you did end up menstruating, then you would get pregnant. Not menstruating, but releasing, and if you're ovulating, if you ended up ovulating by some chance, then definitely you can get pregnant without birth control. But here you need oral contraceptives because you're really trying to stop that entire hormonal cycle of things that are occurring because you're not menstruating, right? So that's the concept here. You want to stop this overthrow of FSH, overflow of estrogen, other things like that. So if you're not menstruating, turn off the hormones, right? That's the concept here. So if you're not trying to get pregnant and you're not menstruating, take oral contraceptives, right? That's also the main thing for PCOS. With tumors, of course, get rid of it, right? And with prolactinomas, there's going to be 2 answer choices, whether it's going to be the dopamine medications like cabergoline or bromocriptine, or surgical intervention where you get rid of the prolactinoma. This really depends on how big is the prolactinoma, because if the patient does not have hemianopsia, the patient doesn't really have severe prolactinoma problems like decreased libido, then the cabergoline and stuff like that should be enough to fix the general list of problems that are there, like a little bit of libido difficulties, a little bit of not menstruating stuff and whatnot, and then they should be able to sustain just fine on the cabergoline or bromocriptine. at which point you would not have to do excision. But if they're resistant to the medication and things are getting worse, then yes, you'll have to do, of course, excision. Last one, premature ovarian failure. Someone who's basically become menopausal under age 40. If the uterus is present, treat with combined oral contraceptives or estrogen plus progesterone replacement therapy. That's it. Hope that helps. So let's take a look at some of these practice questions and really get down everything that we've been basically talking about right now. So the first one we're looking at is right here. 15-year-old girl. All right, so let's do this. A 15-year-old girl is brought to the office due to irregular periods. Menarche was at age 13, so that's good. And since then, her periods have been irregular, with cycles varying from 3 to 8 weeks. She has no chronic medical issues, has never had surgery, takes no medications. Mom and older sister have PCOS and both take oral contraceptives. She has never been sexually active. Vitals are normal. Physical exam shows normal hair distribution with Tanner stage 5 secondary sexual characteristic. So this is great, right? Normal hair distribution means that there's no androgen sensitivity. Tanner stage 5, so she's actually 5 for age 15, which is perfect. Tanner development, so secondary sexual characteristics developing just fine. Abdominal exam is fine. There is dark red blood noted at the cervical os with no active bleeding. So that could be something concerning because there shouldn't be any blood. So we'll highlight that. Dark red blood at the cervical os. Serum prolactin and TSH are normal. Administration of micronized oral progesterone results in withdrawal bleeding in 3 days. So they did the withdrawal test, the progesterone withdrawal test, and there was withdrawal bleeding. Pelvic ultrasound reveals normal ovaries and uterus, so it is a girl because there is a uterus, and the ovaries are normal, so it's not PCOS. What is the most likely explanation of her irregular periods? Insufficient gonadotropin releasing hormone, and that's the only answer choice that's left. I'm not sure how somebody may have picked excess LH, but 20% of people chose that. There must be something that they were thinking, but it really isn't something that rings a bell to me at all. If everything is fine, secondary sexual development is good, your ovaries are fine, your uterus is there, all your other hormones are fine, right? They told you prolactin and TSH are fine, so everything is fine. That means your reproductive endocrine, perfect. General endocrine, perfect. Anatomic development, perfect. So then the only thing that could be wrong now is something in the brain, a central issue. Gonadotropin releasing hormone must not be working. Right? The initial menstrual cycles in adolescents are irregular and anovulatory, which is a normal physiological thing. The abnormal uterine bleeding that follows menarche is due to immaturity of the developing HPO axis that produces inadequate quantities and proportions of GnRH, and subsequently, of course, inadequate amounts of FSH and LH required to induce ovulation. In the absence of ovulation, menstrual cycles lack their regular periodicity. The endometrium builds up under the influence of estrogen, but without the influence of progesterone, the cue to slow the endometrium is lacking, and the menstrual-like bleeding occurs due to estrogen breakthrough bleeding, which is why there's a little bit of blood there, but it's not really, like she might be spotting per se, but it's not real menses. Normally progesterone is made in higher amounts by the corpus luteum right after ovulation, and withdrawal of this progesterone as the corpus luteum breaks results in menses. In patients with abnormal uterine bleeding after exogenous progesterone administration confirms normal endogenous estrogen and progesterone. Normal endogenous estrogen and proliferative endometrium, but not normal endogenous progesterone, right? That's why when you gave progesterone and you stopped it, they started bleeding. It also eliminates causes of estrogen deficiency, like primary ovarian insufficiency would not be an answer, endometrial abnormalities would not really be an answer, and outlet tract abnormalities would also not be an answer. You would knock out all these answer choices with one test. Right? Once you do the progesterone withdrawal test and they do bleed from the progesterone withdrawal, that means everything was working and you just need a progesterone. That's it. When you do a progesterone withdrawal bleed test and there's no bleeding, then there's a lot of things that could be there because something is not allowing you to make estrogen and you need to pick one of those answer choices. Treat abnormal uterine bleeding in adolescents with either progestin only or combination estrogen progestin oral contraceptives if the bleeding is disruptive, heavy, or results in anemia. And ovulation typically resolves in 1 to 4 years after menarche, and the menstrual cycle normalizes. So now here we're seeing etiologies of primary amenorrhea, right? We looked at constitutional growth delay. There's hypogonadotropic hypogonadism. So this is pretty much secondary, right? Where you don't make gonadotropic hormones, GnRH. You don't make GnRH. So that's why you don't make the gonadic hormones LH, FSH. So now if you don't make LH, FSH, you will not make estrogen and progesterone. So now this leads to a lot of problems, right? The etiology could be many reasons this occurs. On STEP, it's a very common one to see excessive exercise, right? Or excessive dieting. Those are very commonly tested on STEP. Usually in combination with other things also from psychology, like bulimia nervosa and stuff like that. Hypergonadotropic hypogonadism means that it's mainly a primary gonadal issue, that you have hypogonadism, but your body or your brain is responding to that and trying to make FSH. So remember, there was always one key issue, right? So here this is the key issue, but here the hypogonadism, this is the key issue. So you're not making enough estrogen and progesterone here because your ovaries have failed to make estrogen, but your brain is trying to help by making more GnRH, which then causes you to make more LH, FSH from the pituitary, and all of that is going to be at a loss, not going to work. And ovulatory problems can have any GnRH, but generally speaking, they should have normal LH, FSH, and the problem is really just going to be with either estrogen receptors, or there's going to be an immature HPO axis, right? Anovulatory problems. Anovulatory cycle is very common. Another way anovulatory cycles can present, besides the one we just looked at, this is one case scenario, 3 to 8 weeks. So she has anovulatory cycles, but everything was perfectly fine with her, and in another few years, her cycles should become very normal. It's just immature, so it's insufficient GnRH secretion right now because her body's still learning. But another case scenario could be a girl that has menses and then doesn't have menses for a long time, and then after that she gets a very heavy menses. So maybe every 2 months or every now and then she'll miss a menses, not have a period on a certain month, and then the month after that she has a very heavy period. Those are things that can occur. That's also anovulatory cycles, and you don't really need to do anything. There's no real treatment there. You just tell them everything's fine, go home. Last one, anatomic problem. Well, here you're just gonna fix the anatomic problem if you can. And all the hormones should be perfectly normal, right? So take a look at this workflow with this question. So let's see what's happening here. Now we have a 14-year-old girl brought to the office because she has not started menstruating yet. Okay, some girls do start at age 15. It's very rare, but it does happen. She is otherwise healthy and has no chronic medical issues. She takes no daily meds, doesn't smoke, drink, or use drugs, isn't sexually active. Mom and older sister underwent menarche at age 13. Height is at the 15th percentile, so that's on the lower end. On the lower end for sure, but not like on a... Actually, I always say 15 is the pathology on the lower end, and 85 is the pathology on the higher end. So I guess her height is sort of on the pathologic side, but everyone's different. So maybe in like another couple months you'll have a growth spurt and she'll grow taller. But for our intents and purposes, we're going to consider this, she's short, too short for her age. And weight is at the 20th percentile. Vital signs are normal. Physical exam shows normal heart sounds without murmur. So normal heart sounds without murmur helps you kind of rule out Turner syndrome, right? Because we know in Turner there's practically 100% chance for the bicuspid aortic valve. There is no breast development or axillary hair. Now this is starting to look concerning, right? No breast development, so no estrogen, and then no axillary hair really tells you that there's probably no pubic hair either, which, pubic hair encompasses both pubic or sexually developing hair, encompasses both pubic hair and axillary hair. They both matter. So this could be androgen insensitivity. The abdomen is soft, non-tender, non-distended. Pelvic exam reveals normal external female genitalia and no pubic hair too. See? Ultrasound confirms presence of a uterus, so it is a girl. There is a uterus there. What is the best next step in her management? So this question really is just reeking of androgen insensitivity, right? So that could be the thing here. This would be the perfect presentation for that. So let's take a look at what would you do. They just want to know what's the next best step in our management. What should you do next? What should you order to check for next? Well, right now, all we know for sure is that it looks like there's no estrogen activity, right? There's no estrogen activity. So there's two things you can do to check whether or not there's estrogen activity. You could do the progesterone withdrawal test, or you could check for FSH levels. Because one of the other reasons you might not have estrogen is because you don't have follicles releasing estrogen. So if you don't have follicles, your FSH levels should be very high, right? So these are some things to understand. Both answer choices will not be there because you can not have two equally correct answer choices. So here you can see FSH level was the correct answer choice, but 25% of people chose the very difficult, challenging answer choice, reassurance and observation, and 15% chose karyotype analysis. Now, picking reassurance and observation is easy and hard. It's a very vague thing. Here, it's easy to understand it's not reassurance and observation because there is a red flag symptom, the lack of pubic hair, right? There is a red flag symptom that she's almost 15, which means she should be approaching Tanner stage 5, but she's nowhere close to Tanner stage 5. There's no breast development. So there's definitely a problem here. So you can't just do reassurance and observation here, right? Reassurance and observation is the answer choice to pick when there isn't definitely a problem. You know, but here we see a problem. There's something that's just not okay, right? So FSH level. So what's happening here? Well, she has primary amenorrhea, the absence of menarche in girls aged over 13 with no secondary sexual characteristics, right? Or girls who are aged over 15 and do have secondary sexual characteristics. Initial evaluation is with a pelvic ultrasound to determine the presence of a uterus. In those with a uterus, such as her, because when you find the uterus, you know that the reason she doesn't have amenorrhea is not that she's not a girl. You know, that can be a thing, right? Someone can come in with amenorrhea, but it turns out they're not a girl to begin with. So you look for the uterus, you figure it out that it is a girl. In those with a uterus, such as her, the best next step is an FSH level, which helps distinguish between central and peripheral causes of amenorrhea. In the HPO axis, central causes of amenorrhea have a low FSH due to decreased hypothalamic GnRH or decreased FSH production from the anterior pituitary. Peripheral causes have high FSH because they're trying to turn on the peripheral problem. So the FSH is going to be made a lot because maybe you're trying to fix the ovary, right? So due to a lack of ovarian estrogen and inhibin production, which leads to a lack of feedback inhibition to the hypothalamus. After this additional testing based on the FSH level can be performed, after this additional testing based on the FSH level can be performed for specific etiologies where you would do the karyotype analysis or MRI of the pituitary depending on what happened. But so far, looking at the way this question is with the lack of axillary and pubic hair, this girl most likely has androgen insensitivity, right? Because nothing is happening. So if FSH level is tested and FSH level is very low because you are making a lot of estrogen, then that means that this is probably that at that point you're pretty much confident that it is androgen insensitivity syndrome. There's going to be a lot of estrogen, very low FSH. It's just that all that estrogen is ineffective. It's not working. Nothing is being affected by all that estrogen. All right. So if you look at this table now, this is your general workflow for primary amenorrhea, right? So now in this workflow, you can find out one of two things. You're either going to find out that it's a guy, so you're going to have that 46XY, normal male testosterone levels, and then you know it's androgen insensitivity syndrome, or you're going to find out that it's a 46XX normal female that may have Mullerian agenesis. That's the other thing that can happen, but in this case scenario, this doesn't fit that at all. This is because she has a uterus, you know, so it doesn't really fit the androgen insensitivity aspect either. If there was no uterus though, then it would be solid androgen insensitivity syndrome. That's definitely a key takeaway from this question. But there you can see how they're really trying to key you in on certain things. You know, they're going to try to confuse you as much as they can by telling you these vague answer choices or vague issues. And for this 14-year-old girl, after figuring out what's happening with the FSH, will know a lot more because her lack of pubic hair and axillary hair, her lack of Tanner development, it's all problematic, you know. And the specific issue can only be figured out after you check for FSH, right? And here you can see the different things you would see in FSH problems, right? For her, it could just be that her ovaries don't work at all, so there's no estrogen, so that you would have high FSH, right? because she doesn't do any of these other things as far as we can see. Low caloric intake or excessive exercise is not there. So you get a patient isn't menstruating. So now what? Well, we already did the first thing. Remember, the first thing was do the pregnancy test. Now after that, you need to check for the uterus, right? So remember that workflow coming back up here. This is primary, right? So you perform pregnancy test, then check for anatomic abnormalities, right? Uterus present or not, and then check for androgenic things. So right here, that's what we're doing. The very first thing was doing the pregnancy test. Turns out the pregnancy is negative. Okay, great. So then why are you not menstruating? Well, you check the uterus. If the uterus is missing, it's one of these two answer choices. Either you're a guy who has androgen sensitivity syndrome, so you look like a girl, or you're a girl who has Mullerian agenesis, so you can't really menstruate, but everything else is developing fine, right? She just can't menstruate, but breast development, hair development, all should be perfectly fine. If the uterus is present, then you need to check for FSH, because if the uterus is there, then the only reason you won't be menstruating now, anatomically everything's okay, pregnancy is not happening, right? There's no pregnancy, so then the only other reason you might not be menstruating now is because you never even developed the endometrium to a point where you would menstruate, right? Now when you check for FSH, it could be low. If FSH is low, that means that you must have high estrogen, right? Your follicles are working really, really well, and they're turning off negative feedback. They're turning off the FSH. So then if your estrogen is working really, really well, then some other hormone must be the problem, the general endocrine. So you check for TSH and prolactin, right? And for the prolactin, TSH, a lot of these things, you would check different answer choices, but cranial MRI is one way to go to check for the prolactinoma. You could also have a pituitary adenoma that makes TSH as well. So, the flat pig hormones basically. So cranial MRI is usually the answer choice to pick at this level. If the question is about hypothyroidism, as we said, the patient is going to have many things in her presentation. Gaining weight without really wanting to, having constipation, feeling cold, stuff like that. There's going to be a bunch of symptoms: really bad hair that's breaking, weakness, fatigue, anemia, foggy mind. The lack of thyroid hormone affects everything from head to toe, right? So that's how you think about it. Everything is not going to be working top to bottom. If the problem is prolactinoma, then of course the decreased libido is going to be the main thing there. If it's a young girl who you can't really gauge the libido of, then at that point, you want to figure out some of the other prolactinoma problems. Like prolactinoma is prolactation, so maybe she's having some level of some discharge from the breast. It could be just the visual disturbance from the prolactinoma expanding too much in the optic chiasm. And if everything is normal, so this is all normal, right? If you're going this path, this is all normal. That's normal, right? This is normal, and then normal, then that's functional hypothalamic, what do they call it? Amenorrhea. That's the normal path, at which point you don't need to do anything. She's just immature right now. Eventually this will develop better and her HPO axis will become mature, and then she will have her menses more regularly, right? So there's nothing to do at that point. Now if you check for FSH and FSH is high, then that's pretty obvious that you must not be making any estrogen. So now you need to figure out, why are you not making estrogen? So you do the karyotype. Are you not making estrogen because you have Turner syndrome, where you have streak ovaries, so the ovaries don't make estrogen? Or are you not making estrogen because of primary ovarian insufficiency, 46XX? So remember, there are two types you have to do a karyotype. Here, when the uterus is absent, and here, when FSH is high. Both of those are answer choice, do a karyotype. But the reason for the karyotype is different. When the uterus is absent, you do a karyotype to confirm, are you even a girl? Right? And then you find out it's a guy that looks like a girl because of androgen insensitivity syndrome. Or you do the karyotype here to confirm Turner syndrome, where it would make sense to have amenorrhea because the streak ovaries and not enough estrogen to even cause menstruation, right? So this workflow pattern, as usual with all the workflow patterns, these are the things you get your questions on. All the step 2 CK, like 90% of step 2 CK questions are just based off of the workflow. And as usual, all of these are going to be answer choices. So you can't pick the correct answer choice unless you have good memorization and understanding of the workflow. Why would you order something first before ordering the other thing, right? So again, like, you might get a primary amenorrhea question where all they did was order the pregnancy test and they tell you it's negative, and they'll be like, what's the next best step? The correct answer would be to check for uterus, right? But the other answer choice of check FSH is also going to be there, but that's not the correct answer, right? Because first you need to check the uterus, which is the next best step. After that, the next best step is checking FSH. So they're both going to be there. Both answer choices are going to be there. You need to know the order in which you check things: HCG, uterus, FSH, and then after, depending on what the FSH is doing, high or low, you would have an understanding of what's wrong, right? So the only time where FSH is normal is where you have an imperfect hymen, which means that you are menstruating, it's just not coming out because there's no opening for the uterus to expel the blood. So you got a hematocolpus, a big bag of blood behind the hymen. All right. So that's the only normal FSH scenario there. But checking FSH is like kind of the key thing. It'll give you the answer basically. You know, you'll know exactly what's happening off of that. Okay, so now this is the same table from, you know, UWorld itself. Nothing special, but there are some key notes I've put here regarding some other things that you need to understand. So let's take a look at that. In first aid, they have right here, remember we said uterus present, yes, no, and then that was its own thing, right? And then presence of secondary sexual characteristics is the development part that you need to figure out. So this table, I feel like for one of the first few times, the table that's in first aid is better than the one in UWorld, right? So of course, when a patient comes in with primary amenorrhea, you do a history and physical exam, and that's done, right? And of course, you check for pregnancy. So I don't know why they keep forgetting to put that here. Like that needs to be there. That's like the key answer choice. Check for ACG. Right? You do the physical exam, you check for ACG, make sure she's not pregnant. Great, she's not pregnant. So now you do presence of secondary sexual characteristics. If secondary sexual characteristics are there, breast is there, pubic hair is there, then, well, pubic hair not so much, but breast is there. Secondary sexual characteristics, the breast development is there. Then you need to now check, okay, the breast is there, is the uterus there? So now you check for the uterus is also there. Then is there an outflow obstruction, maybe an imperfect hymen, or maybe something else is causing the issue, like secondary amenorrhea, such as maybe obesity, you know, so something like that, or really bad diabetes. So that's the breakdown they're doing here. So this path should be very logical, right? All of them are logical, but this should be very logical to begin with. This is the first one we looked at. Secondary sexual characteristics are there, uterus is there. Then what the hell's the problem? You know, everything is good, so then what's the problem? Well, if uterus is there, maybe you have an outflow obstruction with the imperfect hymen. So you're having menses, it's just not coming out. So you need to open the hymen. Or there's no outflow obstruction because the only reason you're not having menses is some other secondary problem, like diabetes, obesity, prolactinoma, something like that. Okay, so that part's done. Now coming back to the beginning, right? You do the checking for pregnancy, not pregnant. Presence of secondary sexual characteristics, yes. Uterus present, no. So you have the breast development, but there's no uterus there. So then now you need to do a karyotype to check, is it a guy or a girl? Right? It could be a guy who has breast development because he has no sensitivity to testosterone, or it could be a girl who has Mullerian agenesis, so she never really made the uterus parts that would be necessary for menses. So that's not so bad either, right? So here is case number 1 of doing a karyotype. Now, back to the beginning again. You do the pregnancy test, she's not pregnant. So we understand now for all these future case scenarios, she's not pregnant. That is not the reason she's not having menses. She is definitely not pregnant. Okay, great. Are there secondary sexual characteristics? No. So then now you're wondering, wow, why are you not developing breasts? Maybe you're not making estrogen. So you measure FSH, LH. Mainly you're measuring FSH, but say both. Now if there's low FSH and LH, so low FSH, then that must mean that you're not making, you know, there's really only one key reason you're going to have low FSH, and that's a hypogonadotropic hypogonadism. You have low FSH because you're not making FSH. That's it. You know, the other reason you could have low FSH is because you have a lot of estrogen. But if you have a lot of estrogen, then you would have the presence of secondary sexual characteristics. Right? So make sure you understand that there are two reasons you could have low FSH. You're making a lot of estrogen, so you don't need to make FSH anymore, or you're not making FSH at all. So the difference between these two case scenarios is if you're making a lot of estrogen, then you should have secondary sexual characteristics. Right? So we already ruled out the fact that you must not have estrogen if you're not developing breasts at whatever age, 13, 14, 15. So then the low FSH LH here indicates that you're not even making FSH. So now you know where the problem is. It's a central problem. So you just need to do hormone replacement therapy here. Right? Very obvious. If you measure FSH LH and FSH is very high, then that must mean you're making a lot of FSH in hopes to turn on estrogen production, which means you're not making estrogen from some other root cause. So why are you not making estrogen? So now you do another karyotype analysis again. So you see number 2 is also karyotype analysis. So it's a very good answer choice, which I don't even know how they misspelled it as karyotype. This was a karyotype, but this is a first aid thing. So now you're doing a karyotype analysis to check once again, in both of these case scenarios, regardless of which path you go down, a karyotype analysis seems to be the final thing to check for. So one thing I want to point out is that since it's the final thing to check for, it's often not the correct answer choice, because the question is always what's the next best step. So you need to go in order. So one of these things may not have been done yet, so you want to make sure those things are done. Did you check for the uterus? Did you check for FSH? Did you do all of those things? All of these things need to be checked, and then you do karyotype analysis. So if for example, you can't jump to 1 over here if you didn't do the uterus check yet, and you can't jump to number 2 over here if you didn't do the FSH test yet. Okay, if everything has been done, then yes, you do the karyotype analysis here, right? Why was your FSH high? Are you someone with 46XY Swire syndrome? So this is a new thing here, so I'll talk about it. Are you 46XX female, but we just don't have working ovaries? Then that's obvious now. Or are you 46XO Turner syndrome? I don't know why they wrote Y. So that's another bunch of typos in first aid, right? So you have to make sure you fix those. If you don't have the paid version of Foxit or some kind of PDF editor, then just make a note for it yourself, right? Put the XO in there. Spelling typos are not a big problem, but if you could fix them, you fix them. I wouldn't really worry about it too much with the spelling errors. But yeah, this is the 3-way breakdown here, so make sure you get that, right? So if you do a karyotype analysis of a girl who came in with no amenorrhea, is not pregnant, has high FSH, and you find out it's 46XY, then it's not a girl, right? So what is Swire syndrome? Swire syndrome is a rare disorder characterized by the failure of sex glands, testicles or ovaries, to develop. These patients look female and have a functional vagina, uterus, and fallopian tubes. However, similar to Turner, they do not have ovaries, so you see gonadal streaks, right? But there's a difference between Swire syndrome and Turner syndrome, which was the mistake they had here. So Swire syndrome is 46XY, Turner syndrome is just 46X, just 1X, no Y, right? So those are some things that you're going to see in questions. Very important thing to keep in mind here, right? And then here we're seeing the prolactin and amenorrhea axis over here with the anovulation because of too much prolactin causing inhibition of GnRH secretion, right? So that's something we already mastered in step 1. So now we can look at some of our step 1 things and a bunch of CK questions. So these are CK questions. These are snippets I took from the step 1 book, right? And then how to do all the differentials between the various main issues: Mullerian agenesis, lack of Sertoli cells or Mullerian inhibiting factor, lack of 5-alpha reductase, Klinefelter, Turner, androgen insensitivity, and Kalman syndrome. How do you differentiate them without any hesitation? So let's take a look at this first question here. So we have a 15-year-old girl comes to the office because her menses have not started. So again, that's Tanner stage level 5, right? That's like the ultimate, that's it, you're there. You should definitely be menstruating. If you're not menstruating, Tanner stage 5 level breast should be there. However, she feels embarrassed because her friends have been developing and she looks younger than her peers. So it seems like breast development might not be there. She has no headaches, visual changes, abdominal pain, or behavioral changes. So the headache and visual change part kind of sort of helps you rule out pituitary adenoma, but not entirely. Remember that you could have a tiny pituitary adenoma also, right? There was always the issue of micro or mega pituitary adenomas. So if you have a tiny one, it still releases prolactin, so it still causes amenorrhea. So thereby you still have pituitary adenoma, but it's not big enough to compress the optic chiasm and cause headache and hemianopsia. So that doesn't always rule it out, but it could. Her mom and maternal grandma began menstruating around age 13. She is not sexually active, is not on contraception. Height is terrible. She's super short. So that kind of really makes you think Turner syndrome. Weight is fine. She's not very heavy because she's not that tall. Vital signs are normal. Physical exam shows no breast development. Normal external female genitalia. So external female genitalia doesn't mean shit. Always remember that. Because what you see on the outside is not what determines what's happening. You know, like the breast development, remember that even men can develop breasts. So seeing breasts doesn't make somebody a female, right? Seeing external female genitalia doesn't make somebody a female. It could be somebody who has no internal female genitalia, then they're definitely not female. So as usual, it's what's on the inside that matters. Always remember that. It's a very cliche statement, but it's actually very logically obvious, right? It makes sense that what's inside is what matters. If you have external female genitalia, but you don't have internal female genitalia, so then how are you a female? You're not a female, right? So that's the key thing to keep in mind there. So they said no breast development, but there is normal external female genitalia. And Tanner stage 1 hair development. That's terrible. She's 15. It should be Tanner stage 5, Tanner stage 4 at the least. Urine beta ACG is negative, so great. They already did that. They did the pregnancy test. Perfect. That was the very first step. The first step in management is that. If they didn't do that, then if they ask you this question, part 1, what is the best next step in management? The answer would be check for pregnancy. You need to check for pregnancy. Got to do that. Why? Because it's super easy. It's like, it doesn't cost shit. It's super easy. You do it. Gets one thing out of the way. But they did that already. So now what do you need to do? Well, you need to do exactly what I just said, which was we see normal external female genitalia, but do you have internal female genitalia? So you do the pelvic ultrasound. That's it. You know, just because you have a vagina on the outside doesn't mean you also have the proximal internal part of the vagina also, and the internal organs of the uterus and all of that. You know, so we need to do a pelvic ultrasound. The first step is to see if she has a uterus or not. The first step, I hear how they word it, is not the first step, the next step, right? The next step is to see if she has a uterus or not. The first step was to do the urine ACG. Primary amenorrhea is the absence of menarche at age over 13 with no secondary sexual characteristics. The other case scenario was someone who's age 15 with secondary sexual characteristics but just isn't menstruating, right? There's two types of primary amenorrhea. In those with secondary sexual characteristics, primary amenorrhea is the absence of menarche at age 15. Right, so those are two types of primary amenorrhea. Her case scenario is the first type, where she's over age 13 but no secondary sexual characteristics. So what's up with that? Amenorrhea can result from either functional or anatomic problems of the hypothalamus, pituitary, ovaries, uterus, or vagina. Thus, the first step in management is to evaluate the female reproductive tract with a pelvic ultrasound to exclude anatomic abnormalities of the ovaries, because it's easy to do an ultrasound and also very cheap. Uterus or vagina. If anatomically everything is fine, then we need to do something that's a little harder and more time taking, because you're not going to figure it out immediately, and that's to check for her reproductive endocrine, right? Does she have FSH? If FSH is high, then you're not making estrogen, right? Which is why your central brain is trying harder to make you make estrogen. If FSH is high, we need to now karyotype, while if FSH is low, we need to do a cranial MRI to check why you're not making FSH up here, right? A high FSH indicates that the ovaries may not be working, so that could be primary ovarian insufficiency, which by karyotype you'll figure out if it's Turner syndrome or whatever, right? So the pituitary is making more FSH and efforts are producing estrogen. A low FSH necessitates further checking TSH and prolactin levels if the cranial MRI is insignificant. So you do a cranial MRI, that doesn't tell you anything, then you check for TSH and all those other things, right? As dictated by this workflow. That's why I put cranial MRI here, right? And before uterus, it's supposed to be checked for ACG, right? The whole workflow would be more complete in that aspect. So that was only part one. Part one was what's the next best step. You do the pelvic ultrasound. Okay, great. Now they go to part two. The patient undergoes further evaluation with the pelvic ultrasound, which reveals a prepubertal uterus with small ovaries. Lab findings give a high FSH of 60 and an LH of 30. What is the most likely underlying cause of her condition? Well, if she has a high FSH, then she's really trying to make estrogen, but it's not working. So the most likely cause was congenital absence of an X chromosome, right? It could be Turner syndrome. That's the most common thing, right? So they go on to say, and of course there was many reasons for you to think Turner syndrome. She's also super short, and she has no breast development, so that fits the scenario of being short and having shield chest, right? That's what they call it. So congenital absence of an X chromosome. Turner syndrome is a sporadic chromosomal disorder caused by complete or partial deletion of an X chromosome. Absence of the second X chromosome results in gonadal dysgenesis, as in her, which presents with streak ovaries, which they described in the ultrasound, small ovaries, on pelvic ultrasound. Due to loss of ovarian function, primary ovarian insufficiency ensues, and patients with Turner syndrome have low estrogen levels, resulting in primary amenorrhea and lack of breast development. Low estrogen also inhibits the negative feedback on the HPO axis, so you get a lot of FSH and LH production. However, since Turner does not affect the adrenal glands, normal adrenarche occurs and patients develop pubic and axillary hair, unlike androgen insensitivity syndrome, where LH would be high, but the lack of receptors leads to lack of axillary and pubic hair, right? So doing the karyotype would be the next thing, right? After you check for FSH, after you check for pelvic ultrasound, you would check for her FSH, which they did, and then after you check for FSH, you would do the karyotype, which was the answer choice here. Okay, so now we're looking at all the different things you needed to recall from step one, right? So in step one, we learned that FSH goes to the granulosa cells, LH goes to the theca cells. These are both inside the ovary, right? The theca cells make the androgen precursor, which then aromatase converts into estrogen. You need both FSH and LH to do this. LH is almost always there. We really only count FSH, and that's all we really check for. And then over here you're seeing the male version of it, so I put it here for completeness purposes. In men, you have FSH that goes to Sertoli cells, which are your nurses for spermatogenesis, and LH that goes to Leydig cells, which make testosterone, because remember, ladies love testosterone, right? So that's kind of how you remember that. So Leydig cells make testosterone, and without these guys perfectly working without the testes, you would lose negative feedback, and FSH could be very high, right, in men, in the male version of things. But we'll see more of that when we find more of the male gynecologic problems, but there really aren't any per se, just developmentally, which we're going to be looking at right here. Sexual differentiation, how does it initially all begin? So in the fetus, you're initially an undifferentiated gonad. The standard mode of development is female. So if you need to become a male, a lot of things need to happen. So the standard female development starts from the cortex. Remember, this is now something that may get tested. You probably didn't know this, right? The medulla versus cortex part, that where the changes occur determines who you are. So if a question is telling you that gonad differentiation began in the cortex, you must be becoming a female. Whereas if the gonadal differentiation started in the medulla, you must be becoming a male. This is very rarely stressed, but it is something that you can easily get tested on. So critical little thing here. So now with female development being the normal standard, like that's the pre-built mode. Everyone is initially designed in the fetus as standard female, and then the presence of Y chromosome is what changes gears to becoming male. So ovaries would just make estradiol, which would give you the external female genitalia, but what really matters is the internal stuff with fallopian tubes, uterus, and proximal vagina, and that requires a Mullerian duct. This is why we do a karyotype, so that when someone doesn't have the uterus, the internal thing, we need to check if you actually are female. Because if you actually are female, XX, but you don't have your uterus, fallopian tubes, and proximal vagina, then you must have Mullerian duct problems. Right? Something didn't allow your Mullerian duct to develop. So now understand that every time we check for the uterus, when the uterus is missing, essentially all three of these things must be missing because they come from the same source, right? So then that explains why the person is not menstruating, because you also need your fallopian tubes for ovulation, in a sense, right? You need your uterus to have that endometrial lining, and you need your proximal vagina for correctly having everything designed. So when when one is missing, it really means all three are missing, and that usually is a really concerning thing. So that's what we really care about. You see, so you can tell that having a clitoris, having the distal vagina on the outside, or having the labias doesn't really mean you must be a girl, right? Because you could have those things, but then you don't really have a fallopian tube, uterus, or anything else, right? So this is the one that you kind of develop when you are XX and when the ovaries are working and they make estrogen. Remember, each of these things have to be checked. You are XX, you are making estradiol, so then you get these three things. But you can still have amenorrhea because these are not the three things that allow you to menstruate. The clitoris, labia, and distal vagina are not what allow you to menstruate. All right, so that takes care of that part. So we get the standard female development. So then how do you become a male? So now to become a male, you need the Y chromosome, which has the SARY gene on it, SRY. That gene causes testes development. Now testes have two things we just looked at, the Sertoli cells and the Leydig cells, right? The Sertoli cells are the caring mothers, the very, very caring mothers that many men have, and it's a pathological issue in many cultures. But those caring mothers, it's something that I was able to fabricate as a story for myself, because it's definitely very common in the Indian culture that you find, women who are allowing their son to do everything and whatever they want, but then the daughter of the house is suppressed, something like that. It's a very common scenario. So your son can stay out till past midnight, but your daughter has to be home before sunset. So that's a huge gap, right? It's obviously unfair, and it's still very common in many households. And that's kind of what you're seeing here, right? You're seeing that the female thing is suppressing what the hold on, my dad is calling. I'm not sure why. Hello? He called like 3 times. Something must be wrong. Hello? Oh, he's butt dialing. Great. Okay, excuse me. So that's kind of what you're seeing here. You're seeing that the caring nurse cells are allowing the male development to occur, and they suppress the female development, right? So that's kind of analogous to a story I was kind of fabricating here, because it helped me memorize this. I memorized Leydig cells make testosterone with the whole ladies love testosterone in men. So Leydig cells make testosterone, so that's pretty easy. And of course that testosterone is what's going to lead to the rest of that development as you're seeing here, right? All of this. But Sertoli cells are the caring nursing moms that will suppress the female development, right? Because remember, standard development was female, so you need to turn it off if you're making a male. So the Mullerian inhibiting factor inhibits the Mullerian paramesonephric duct from developing, right? That's kind of something very critical that can actually go wrong in men who don't have Sertoli cells. So you need to understand, if you're a man without a Sertoli cell development, think of what's going to happen now, right? Men without Sertoli cells are going to have testes that release testosterone. They're going to have mesonephric Wolffian ducts that are going to give them the internal male stuff. They're going to have external male genitalia, in which testosterone is successfully going to upregulate. And they never turned off the paramesonephric duct. So they're also going to have internal female genitalia. That is a tricky question. So how those questions will work is that you'll see, they'll describe it as a patient with vague or ambiguous genitalia, because they're going to have a proximal vagina and a penis. So they're in questions, they'll just word it, they'll never really say there's a proximal vagina and a penis. If they say that, it's making things easy for you. What they'll really say is there's ambiguous genitalia. They'll tell you, what do you do next? Or maybe they'll actually do the pelvic ultrasound for you, and then they'll tell you that there's a uterus and there's something like a scrotum outside. So then, these are all case scenarios where you basically understand that you never turned off the standard female internal development, right? So that's the only thing you need to catch. Is there a uterus and there's the internal male and female stuff? Then that's it. Internally you're male and female, so you never stop the female development, so you don't have Sertoli cells. Forget the external stuff. Never pay too much attention to the external stuff. All we really care about is the internal stuff, because the internal stuff is based off of your actual genetic and chromosomal development. External stuff is influence of hormones and environment, right? So internally, you needed the mesonephric duct to make the epididymis, ductus deferens, seminal vesicles, all those things. And you would see them on ultrasound. Pelvic ultrasound will find these things, the ejaculatory duct, which of course then will lead to the penis and the scrotum outside, right? So all of that, if you have both internal things, that means you don't have Sertoli cells. You didn't stop the female internal development, all right? And then the other case scenario is number 2 over here. Maybe you don't have 5-alpha reductase. So this is a far less severe problem. It's okay. So if you don't have 5-alpha reductase, then you don't make DHT. And without DHT, you can't have the potent activation of the penis and scrotum. So male development would be a little delayed. But male development would be there nonetheless. And eventually, as the kid grows, he'll make even more DHT and he'll develop fine. Okay, so that number 2 is not that big of a deal. The only real thing you need to worry about here is number 1, where you don't have Sertoli cells. So that's the only time you get a full male, but with also internal female stuff. So a full male with a uterus, that is lack of Sertoli cells. So now here, of course, is the list of those differentials. These are all the differentials you need to master and be able to figure out. So I listed them out all together here for your comfort. Right, Mullerian agenesis, also called MRKH syndrome. It's a very long name, Mary Ruth Hauser, something weird name. Right, primary amenorrhea due to lack of uterine development in a 46XX female patient, but developed secondary sexual characteristics. Female patient who just isn't menstruating but has Tanner's 3+ development of her body. Initial exam would be to check for uterus with pelvic ultrasound, normal testosterone. Right? Everything's going to be fine, but the only issue is going to be she's not going to have a uterus. And then after that, of course, you would have to do the karyotype, which is the 46XX part. And you'll see that she is 46XX, just doesn't have a uterus, which means Mullerian duct didn't form. Right? And Turner syndrome, remember, has its own things. They're going to tell you the height is not at a good percentile, right? Below the 15th percentile for height, too short. There also wouldn't be breast development in Turner syndrome. There's a bunch of things in Turner syndrome that make it very easy to pick. They can even tell you cardiothoracic exam, and if the heart has some kind of cardiological problem, that's Turner syndrome. So one of the most common answer choices, Turner syndrome, is actually one of the easiest answer choices to pick, because you're going to look for a whole compilation of symptoms. Absence of Sertoli cells, which we just talked about, right? So that we get. Number 3, lack of 5-alpha reductase. We just talked about that. Now we're looking at Klinefelter, Turner. So Turner we talked about, we get it perfectly, right? Klinefelter, that's male with 47 double Y. So 2 male. So, how males are considered to be aggressive. With 2 Y chromosomes, they're doubly aggressive. So that's often a thing that they put into questions. It's not really a first aid clinical example of what Klinefelter is really about, but it is a real clinical example of what Klinefelter is about. Klinefelter males are usually extra aggressive, all right? So you're going to see too much of that. High FSH and LH and estrogen, below testosterone and inhibin, because those things come from the testes, but these guys have testicular atrophy. They're so male, they actually ended up not being very male. It's a very weird thing. The way you want to think about it is men that take steroids. Men that take steroids look more men because they're going to be super muscular and stuff, but then they lose their testes, right? So that's kind of what's happening here. They're so masculine, they lost their testes. They're trying too hard, in a sense, right? So testicular atrophy actually causes them to have lack of testosterone. So you learn that. That's the first thing that shows up in reproductive pathology, right? Klinefelter syndrome. Look at this male. 2Y, sorry, what am I doing? Excuse me. This is supposed to be 46XXY, right? They have 2 X chromosomes. But they're so male with that one Y chromosome that they actually end up having testicular atrophy, and they present like this. So you're gonna get a male patient. Just make sure we fix that issue in the book too, typo. But these kinds of typos are often very critical, so make sure you edit that in your version of the book as well. That part should be editable with any PDF editor. 47XXY, that's Klinefelter, right? There is a double Y one also, and what I said about the double Y one, that's true. The double Y thing is very aggressive. That's right here, double Y males. Right, so they tell you severe acne, learning disability, spectrum disorders, and these guys are the ones that are very, very aggressive. The 47XYY. But what we were right now talking about was Klinefelter, which is not the double Y one. Klinefelter has double X. So of course the double X is supposed to make them a female, but they have a Y that's supposed to give them the male part. So what's going to happen in them is they're going to actually end up getting testicular atrophy. They get this female body development with the hourglass shape, right? Long extremities, really tall, complete opposite of Turner, right? They actually look more female than Turner syndrome patients, which is the weird thing, right? Because Turner syndrome by definition is a female because there's no Y chromosome, right? Here you have a Y chromosome, so by definition that is a male, but it looks very female, and there's going to be an extra, presence of inactivated X chromosome. There's going to be an extra X chromosome bar body, which you only find in women. So when you have a male with a bar body, that's Klinefelter. That's like a very minimal type question you can get where you have to pick that as an answer choice. Be very careful with that. It's like a one-line question. Oh, a male patient came in, you did some check on them, and you find a bar body. What must be the diagnosis? And I don't need to tell you anything else. That's just Klinefelter right away, because a male would not have an extra X chromosome to become a bar body, right? Males only have one X chromosome. So when a male does have an extra X chromosome to become a bar body, that's Klinefelter, right? And then what you get tested on are these things. So you can see this was an answer choice, right? FSH is high, LH is high, but testosterone is low and estrogen is high. The female part in this wins, obviously, because female development is standard, right? So the female part wins. Now look at this question. It's always very obvious, right? 15-year-old patient is referred to the physician by a teacher who's concerned about the patient's learning behavior. Patient's reading and writing skills are significantly impaired compared to other classmates, and the patient often misbehaves in class despite receiving numerous detentions. Cytogenetic studies show a karyotype containing 47 chromosomes. Well, you already know what the problem is now, because it's supposed to be 46 chromosomes, so it must be XXY. And then they're like, what else are you going to be finding in this patient? Well, they're going to be tall, they're going to have gynecomastia, and they're going to have azoospermia. They don't really make much sperm because of the testicular atrophy. That's it, right? So not so bad at all. Just make sure you fix that in your book. Klinefelter 47XXY, which you should definitely already know. I read 47XYY and started talking about 47XYY. That one you should also know. The aggressive male with extra acne and too much Y stuff, too much male characteristics. Here there's too much female characteristics, right? This happens because the mother's egg got fertilized by two different sperms, one X and one Y. Turner 45XO, we perfectly get it. We saw all the things already in various questions. Androgen insensitivity syndrome, keep in mind this is an X-linked recessive disorder. First aid doesn't really mention it very much. First aid doesn't have that written in there either. You do need to know that. Actually, in my step 1 first aid, I've added that in wherever necessary, right? So here we can see androgen sensitivity syndrome, X-linked recessive. It's not in the book, right? The other thing, let me see. Was there another guy that was somewhat? No, that was the only one. Okay. Yeah, just androgen sensitivity, X-linked recessive, right? So X-linked recessive means that you can get it from either parents, right? The Y chromosome, but X-linked recessive, remember that the father, if you're a son, then the only thing you got from your father was the Y chromosome, because your mom can't give you a Y chromosome. So as a son, if you got an X-linked recessive disease, you must have gotten it from your mom. Right? Always got to remember that. It's like a genetics question you can get tested on. Very critical concept here. As a male, you only get the Y chromosome from your dad. So your X chromosome must have come from your mom. So any X-linked recessive, X-linked dominant, X-linked anything disease, must have come from the mom because your mom gave the X chromosome, right? Also, similarly, obviously, your mom can only give you an X chromosome. That's also something to keep in mind. Last one here, common syndrome, could be either gender, right? Patient fails to complete puberty, presents with low GnRH, FSH, LH, and testosterone. Men present with infertility due to a low sperm count, while women present with amenorrhea. Their distinguishing feature is the anosmia. That occurs because of neural crest cell issues. Common syndrome, FGFR1 is inactivated, which manifests as common syndrome with disproportionately long arms. That's another key feature they have. And the real issue was the defective migration of GnRH releasing neurons and subsequent failure of olfactory bulbs to develop. And so this is also relevant for neural crest traveling migration. So very, very unique kind of question, but the anosmia is a giveaway. So oftentimes questions don't really tend to mention the anosmia. And then here we go on to more questions. So 14-year-old girl brought to the office for a routine physical exam. She is starting high school and is going to be on school's cross-country team. All right, great. She has no concerns today. She's healthy and takes no medications. Family history has hypertension in the mom. Everyone has hypertension, so no big deal. She has undergone menarche and is not sexually active. Great. So, she has not undergone menarche. Excuse me. Let's underline that. Height and weight are at the 25th percentile. So right away, we can kind of rule out Turner syndrome. Right, 25th percentile. So she's tall enough. She's got good weight. Physical exam shows sexual maturity, Tanner stage 1. That's not good because she's almost 15, where Tanner stage 5 should be there. So there's no way in 1 year she's going to jump 4 Tanner stages. So she's definitely delayed in breast development. Abdomen is soft, not tender, not ascended. Small, non-reducible mass is palpated in the inguinal area. That's really weird, right? Why would you have some kind of non-reducible mass in the inguinal area? So that could be testes. On pelvic exam, the external genitalia appear normal, but we don't care for external shit. And there is no pubic hair. That we care about because that could mean that maybe estrogen isn't really affecting her, or maybe androgens are not affecting her. Androgen insensitivity is the first thing that should come to mind with no pubic hair. The vagina ends in a blind pouch, so then that means that internally it's just a blind pouch. So internally she doesn't have a vagina. So if she doesn't have a vagina internally, must be a guy, right? Sonogram confirms the absence of a uterus, must be a guy. So now what do? You confirm if it's a guy. Karyotype. Karyotype is 46XY, so it is a guy. Look at that. They started the question by telling you it's a 14-year-old girl, but it's a guy. Alright, so tricky shit. What is the best next step in her management? Gonadectomy. The non-reducible mass that they're feeling in her inguinal area is the inguinal descent of the testes. They're stuck there. You need to get rid of them because they're going to become cancerous. Right, so that's all that is about. A lot of giveaway points in this question. Everything is okay on physical exam, where the Tanner stage of breast should have been 2+, preferably 3 for a 14-year-old girl, right? Except that was the only thing that's not okay. The lack of pubic hair was a key giveaway for androgen insensitivity syndrome, ultimately diagnosed by blind vagina and lack of internal sex organs. The testes are functionally normal but undescended, so to deal with this cryptorchidism, we must remove the testes, palpate in the inguinal canal. They can also be palpated in the labia majora. Right, they can become testicular cancer. So that's all this question was really about. A 16-year-old girl comes to the office due to not having started her menstrual period. She says that all her friends have started their periods and she is concerned. She has had no nipple discharge or change in vision or weight. She has no chronic medical conditions and takes no daily meds. She recently became sexually active and uses condoms. Height is at the 70th percentile and weight is at the 40th for her age. Vitals are normal. On physical exam, there is sexual maturity rating, Tanner stage 4 breast development, and with minimal axillary or pubic hair. So again, I haven't highlighted shit so far, but already without highlighting anything, all things were seeming okay or acceptable until here. That is not acceptable, right? Minimal axillary and pubic hair. If I was highlighting things, I would of course highlight who she is, 16-year-old girl. I would highlight that everything is okay except, this would be highlightable. The actually her height and weight of grade 2, right here, Tanner stage 4 is highlightable because 15-year-olds are Tanner stage 5. Is it acceptable to be 16 years old and Tanner stage 4 breast? Yes. But it's not acceptable to be 16 and have Tanner stage 3 breast. That's not acceptable. That's like way too behind. All right. And this is never acceptable. Minimal axillary or pubic hair? No. The external genitalia are normal and the vagina is 3 centimeters in length. We don't care about external shit. The cervix is not visible. That's an internal thing. That we care, right? They then tell you no uterus, cervix, or ovaries are palpated on by manual exam. That's bad. So this is most likely not a girl, so we need to do a karyotype, right? So lab studies include a negative pregnancy test, great, and they do a testosterone level of 400. That's super high, right? Normal would be under 100 in females and almost 1,000 in males, right? There's a huge difference. So with her, 16-year-old girl, with her, it really looks like it's supposed to be a guy, right? It's supposed to be a guy. So now they had both answer choices. The answer choices are only differentiable by karyotype. They had androgen sensitivity syndrome and Mullerian agenesis. Both of these are the only differentials here that could possibly be the answer. 20% of people still fell for Mullerian agenesis. Now think about it. With Mullerian agenesis, that's this thing. So without Mullerian agenesis, you know, with Mullerian agenesis, without the formation of Mullerian duct, you lose these things, right? So you don't have fallopian tubes, you don't have uterus, you don't have proximal vagina. Sure, but if you're saying that the issue is Mullerian agenesis, then her hormonal levels should be female, and that's not happening here, right? Her hormonal levels are male, so this is a male, so the issue must not be Mullerian agenesis. This is androgen sensitivity syndrome. Basically, in this question, they're telling you that the person is male in a very unorthodox way that you wouldn't do in clinical setting. They're telling it to you by hormonal levels, but in a clinical setting, you have to diagnose this with a karyotype. But they didn't do the karyotype because that would make the question easier, right? That's all that happened here. So this patient with amenorrhea and male range testosterone levels most likely has androgen insensitivity syndrome, where it's male, but he's insensitive to his own testosterone levels. So testosterone has no effect on him. And since testosterone has no effect on him, he's looking like a girl. That's the only thing that happened there, right? Very straightforward, very easy question. There's always going to be two ways of differentiating. This is the unorthodox way with the hormone levels, or the real way, which is karyotype analysis, right? And then this question is the real Mullerian agenesis. So you see how these two questions are perfectly placed here to help you differentiate which case is which. So this question, once again, same beginning, 16-year-old girl. Okay, same beginning. So I love how these questions popped up like that. Is brought to the office because she has not started her menstrual periods. Literally the same first sentence. Okay. Her 14-year-old sister underwent menorrhagia a few months ago, and her mom began menstruating at age 13. She has had no headaches, changes in vision, weight gain, nipple discharge, or abdominal pain. She has no chronic medical conditions and has had no surgeries. She is not sexually active, doesn't use contraception. She plays basketball. Her height is great, very tall actually. I remember 85 was the extreme for the other end, right? So she's really tall for her age. Weight is fine. Vitals are normal. Her height though, although it's 85th percentile here, we're not freaking out about it because she actually plays basketball for a reason, obviously, and maybe she's just really tall. It's okay. But what that does tell you is it's not Turner. Vitals are fine, and then they go on to the physical exam now. Breast, axillary, and pubic hair are Tanner stage 4. Which is acceptable. It should be Tanner stage 5 before it's acceptable. At least she has pubic hair, right? Abdomen is soft, non-tender, and has no palpable masses. On pelvic exam, external genitalia are normal, and the vagina now ends in a blind pouch once again. So that means that the outside vagina is there, the lower 1/3, but then inside the vagina, it ends in a blind pouch. There's no vagina inside. Right? So it's a very weird thing where basically, if you were to look at the vagina and then open it and look inside, it's just a closing. There's no actual endless entry. It's just a closed vagina, right? So it's really just not how it's supposed to be, of course, and that is the same thing we saw up here. So the only difference between the top question and this question were the fact that the one over here has pubic hair, right? The one up here did not have pubic hair. Then the next difference is now going to be the hormone or karyotype they're going to do. So they go on to say on pelvic exam, the external genitalia are fine, but it ends in a pelvic ultrasound. So okay, they did pelvic ultrasound, which is perfect, because once we see that the outside is there, we can see what's happening inside. Pelvic ultrasound reveals bilateral ovaries, but no uterus or cervix. So if you have ovaries, then you must be a girl, right? But there's no uterus or cervix, then that means that it must be Mullerian agenesis. Remember the development, right? The over here, fallopian tubes, uterus, and proximal vagina came from the Mullerian duct, right? And then ovaries help you make the other things. So the ovaries successfully helped you make the distal vagina, but the presence of ovaries, you already know, the presence of ovaries is female, and the presence of testes is male. Not the presence of a penis or a vagina, right? Because penis and vagina are outside. External shit doesn't matter. Internal stuff is what matters. So internally, if you have testes, that's a male, right? And testes, although they can come out in the scrotum, they don't always have to, as we've seen. The undescended testes that's stuck in the inguinal area, right? Because everything develops in the same area at that level of the kidney, right? So this question was most evidently Mullerian agenesis. So you can see the clear difference between the two questions, but there's a lot of overlap, a lot of space for mistakes, especially if this is your 200th question on the test. You can definitely freak out, so you got to stay calm and understand confidently the differences. Last question here, this is actually related to secondary amenorrhea, so we'll continue this in our next video, where we'll once again look at what makes secondary amenorrhea very key and how is it actually different from primary amenorrhea, and then we'll observe Asherman syndrome and push forward. So great session. Hopefully you guys caught on to a lot of things, and I'll see you guys next time now.